How to Read Pediatric ECGs by Park and Gunroth. So this is 4th edition. It's only about 30 quid, and this is a super book. I think every department should own a copy of this book. You should decide which consultant has the most PAs and get them to pay for this book, and just keep a copy in the reg office. It contains all the things on what a normal ECG looks like and all the normal values. It's super accessible. It's not expensive, and I think every department should just have a copy of this in the reg office for reference. Okay, so section 1, some general tips in reporting. So performing an ECG, this is definitely not rocket science. Usually the biggest burden is you think you've got something else to do, but actually I've kind of got to a stage where if it's an ECG and I really want it and it's going to change what I do straight away, I'll just do it myself. And you kind of just need to cross that mental boundary and just deal with it. Lead positions, I don't think too hard about, mostly because they're reasonably obvious. And also most ECG machines have a diagram with all the lead positions on them. So you can just copy it off the machine and you're good. V4R, historical teaching would say that we should all use V4R in pediatric populations. In all honesty, I think most of us now, most of us sort of pediatric cardiologists can't interpret V4R. Don't bother. It's no use to me. But standard lead, and just do standard lead positions. Okay, common problems. Number 1, either nothing on the screen or nothing on half of the screen. There are 10 sticky dots. It's very unlikely you've got all of them wrong. Don't go through and check each one by one. Check the black and the green, which are both of the legs, okay? Which are the leg leads. Check those two. If you've got big lumps of nothing on the screen, several leads blank, it's going to be one of those two. Get in the ECG to print. It's usually the biggest button or the one that says go or ECG, and just keep hitting that until it comes out. Most of the settings you're not going to have to do anything with. The exception is if your baseline is absolutely horrid. Sometimes that is because someone has turned off the 50 Hertz filter. You need to filter out AC. So that's the only thing on the settings that you may have to pay attention to, is usually the 50 Hertz filter. If you've got a poor signal, move your dots to bony prominences and things like anterior superior iliac spine and stuff like that, or the malleoli, just to get, often that gives you a better signal. And if it's all the leads, again, black or green, go for those, all right? Getting right and left the wrong way around, I struggle to really help you with, but sometimes if you've got a really, really wacky ECG that doesn't make sense, it's because you've got right and left the wrong way around. Okay. Reporting. Pretty much anytime if you do an ECG on a child and you don't tell the ECG machine it's a child, it'll tell you that your patient's having a heart attack or it's got massive left ventricular hypertrophy, and that usually causes a not small amount of anxiety and is a frequent reason for referral. Yeah, so it's just not going to work, and you're going to get dodgy reports unless you put the age in. Newer machines are better. They're definitely better, but I still don't think they're quite there, and the accuracy of reporting is not as good as you, all right? So going back to how to read a pediatric ECG. So the classic batting order of rate, rhythm, axis, and then work your way through everything is not actually what I do anymore. And I think this is really my process. And we'll go through the bits of this that I think are a little bit different. So I do a quick visual check, and that's to make sure that the ECG is what I'm expecting it to be. And then as per classical descriptions, I'll do rate, rhythm, and axis. And axis is really important. And I work my way through P-wave axis, QRS axis, and T-wave axis. We'll talk about that. I then look at the R-wave progression through the chest leads. And actually, these first 5 bits don't take very long at all, all right? These first 5 bits give you a huge amount of information. In fact, I'd say most of it I get from there. And then only then do I move on to more clever things. The big pathology that is going to give you, all right? So what do I mean by a visual check? I really mean checking the paper speed is correct and the voltages are what I expect them to be. So 25 millimeters per second is standard speed. And that big block at the side, so one step, the step up on that means 1 millivolt. And it also tells you on the bottom, so next to speed, it tells you the limb leads are 10 millimeters per millivolt and the chest leads are 10 millimeters per millivolt. Those settings can be changed. So if you look at this ECG on the right-hand side, there is a big step up and then a step down. That means that the limb leads are at normal scale at 10 millimeters per millivolt and chest leads are at 5. So don't let it trick you, all right? The other thing, paper speed. So some machines default to do some slightly unusual things. So this machine, this patient has got Wolff Parkinson White, by the way, so did know that. You can make things look really terrifying and make your QRS intervals a lot longer than they are and everything a lot bigger than they are by having the paper speed set to double, okay? And this is just the way some machines are automatically configured. So don't let that trick you either. So I start by eyeballing the ECG and make sure it's what I expect it to be. Axis, for those, this is extremely, sometimes poorly explained, but is actually very simple. And you can make it very simple. So I'm just going to try and bring up a pointer, laser pointer. So I look at 1 and AVF. So positive for 1 means it's leftward, positive for AVF means it's inferior. And normal QRS axis after about a month or so of age is going to sit with 1 and AVF being positive. That's normal. It's going to sit in this range. You're allowed minor variation there, but it's pretty much going to sit around here. P-wave axis is always going to sit in between here in normality, yeah? So you're going to have an upright P-wave in 1 and an upright P-wave in AVF. If you do not, that is not sinus rhythm, okay? And that's an important thing to say. T-wave axis, the T-wave should be upright in 1 and AVF pretty much the whole time, all right? And this is a very quick thing to see, and if it's off, it's abnormal. You're allowed rightward deviation in neonates, rightward QRS deviation in neonates. So to have a -1 and positive AVF, so somewhere over here, axis somewhere over here, is normal in a newborn. You're allowed it then. But after about a month or so of age, you shouldn't really have a rightward axis. R-wave progression. So R-wave progression is something you assess on the chest leads, and it's how the S-wave changes to an R-wave, or the R-wave changes to an S-wave, or how the pattern of the R-wave changes across the chest leads. And it should be a gradual thing across V1 to 6. The neonatal pattern is that the R-wave in V1 should be bigger than the R-wave in V6. You've got an R-wave dominant V1 in a neonate. And this gradually changes to the adult pattern, where you've got a very small R-wave in 1 and a big S-wave, and a dominant R-wave in V6. And this is this pattern. So this is a neonatal ECG. So you've got a rightward axis, so -1, positive AVF. You've got a neonatal R-wave progression. So you've got an R-wave dominant V1 and a small R-wave in V6. And this changes. This is a teenager. So now you've got +1, positive AVF. Small R-wave in V1 becoming a big R-wave by V6. And these are the changes you get through childhood. There are specific ages at which things are acceptable. I'm not going to go through all that today. Life in the Fast Lane website I can go through it, but you'll not remember it. And so in all honesty, if I think something's borderline, I look it up and I check. And I think that's what we should be doing in 2020. You don't have to store all this stuff in your head. All right. So moving on, common queries. So I think these are the list of the most common reasons people send me an ECG, all right? Borderline QT intervals. This is really frequent. So the first thing to say is it's often long in the first few days of life, and it will normalize inside a week. The electronic report of a QT interval is of, as we've said, variable quality. I would always calculate it by hand, and we'll go through that. Scans are good. Faxes are useless. I know we're going out of faxes in the NHS finally. Well, this is an example of a faxed ECG. And there's no way I'm going to calculate a corrected QT interval off this without you giving me some Kepler or something first. This is just not achievable or safe. Scans are good. Send me a scan. That's going to be better. Okay, so what is QT interval? So the QT interval is a cardiac interval that varies with heart rate, sex, and age. It varies with heart rate, so you've got to correct it for heart rate. There are a whole load of available formulae, and every now and then someone comes up with a new formula that they say is better. But in all honesty, everyone uses Bizet's, which is this classic one that everyone knows. So the QT interval divided by the square root of the RR interval. Why do people get this wrong? Okay, so number one, you've measured the wrong thing. I know this sounds ridiculous, but it is frequent that people measure the wrong thing. And they get these gigantic PT intervals where they've measured from the start of the P wave and stuff like that. And then you've got to try and phone them back and explain that that's not what you do without being rude. And that's very difficult. Don't do that. Measure the QT interval. The second most common reason for mistakes are mathematical errors. If you don't use seconds, so fractions of a second, 0.3 or whatever of a second, when you square root it, you will get very, very, very unusual numbers. So you've got to use fractions of a second, of whole seconds in the calculation. The third mistake is not using the preceding RR interval. So when you select a beat or a pair of beats to measure a corrected QT interval in, pick one that looks to align reasonably well for the start of the Q wave, the end of the T wave, and also the RR. Yeah, try and pick one. You should be looking at usually leads 2 or V5. And you want the immediately preceding RR interval, not a random RR interval on the ECG, the one immediately preceding the QT that you've measured. It is 2020, guys, and there are plenty of apps and online calculators which allow you to fill in the number of squares that you're counting, so you don't have to convert to fractions of a second. I haven't converted to fractions of a second for years. I just use an app. It'll improve your life. Electrophysiologists, who I've already alluded to are special people, have special calipers they use to measure it. They have their own special ECG measuring rulers. Maybe you really want to do that. I don't. So I pass on the special ECG measuring rulers. The last thing to say is what you do when you get this slopey downslope thing. What you do is you take the downslope and draw a straight line, you draw a tangent down, and where it crosses is where you measure the back end of the QT. Normal values are there. All right, when someone gives me a borderline QT interval, my first question is it truly long? And I measure it. And then I'm asking about history and why you've done the ECG, and I'm thinking about whether this is acquired or congenital. There's things like age, normative values for age also come into this, drugs, what the underlying problem is, whether it's an electrolyte problem, and then I'm asking about family history, and I'll talk a little more about family history later on. T waves in the anterior leads. So inverted T waves between V1 and 3, you're allowed as a newborn, and they normally become more upright as you get older. Inverted V1 and up to V2, I'm pretty much going to ignore, unless you've got other terrible problems with your ECG. If that's an isolated thing, I'm pretty much going to ignore that. This is more common in Afro-Caribbean populations, okay? And this is just an example. So T-wave inversion, V1, V2, a flattish T-wave in V3. Particularly in a toddler, I'm going to be ignoring this. Physiological Q waves. So you're allowed a Q wave in V6. I think the next page shows this. You're allowed a Q wave, a little Q in V6 and not in V1. It is usually very short in duration. The magnitude of an ECG varies with age and lead. And again, these are something with normative values. And you should just look at, if you think you've got a big Q wave and you're worried about it, just look up what is allowed for that age. All right. So this is just an example. So there's little Q in V6 and no Q in V1. For those who are geeks about this, if you get an inverted pattern in this and you get a little Q in V1 but not in V6, could well have congenitally corrected transposition. A high takeoff. So this early repolarization pattern, so this can cause a lot of anxiety because it can be confused with ST elevation. What are the differentiating features? Well, first up, your patient's probably not having a heart attack. And I think you should be able to tell on clinical grounds that your patient's not having a massive heart attack. It is usually present only in the anterior leads. And the other thing is there are no reciprocal changes. So although there is ST elevation in the anterior leads, there is no reciprocal change. You've not got ST depression elsewhere. And the final thing that's supposed to be very good with this is J-point notching. And this is J-point notching. We get this little upstroke before the true ST segment. It's just an ECG of an example. You get this, the ST elevation in the anterior precordial leads. There's no reciprocal change. I've not got notching on here. This is a very benign phenomenon. And another picture of it. Okay, so an RSR and V1, this partial bundled branch block pattern. So you've got an R wave and then quite a deep S and then an R wave again in V1 and a normal QRS duration, so less than 3 small squares. This is a normal variant. We used to be pretty strict about this being a potential normal finding in Brugada. There's a lot of debate about this at the moment, and you can get it as a type 2 Brugada pattern. I'd be worried in a patient with exertional collapse and an RSR and V1, but by a million miles, the most common context for this is just a benign finding. Okay, and it's this in V1. Okay, big voltages in LVH. So we've touched upon this already. Auto reporting of LVH by voltage criteria by the machine. Children have massive chest voltages. I've heard all sorts of reasons for this: thin chest, thin bones, stuff like that, and voltage coming up. I don't know what the real reason is, but they do get big voltages. And the upper range of normal voltage in children and teenage can be very large. There are a number of methods to diagnose LVH in children, all of which, in fact, I would say are no good. If there was a good one, we'd use it. There isn't. The classic adult Sokolow-Lyon criteria, where you add R waves and S waves together, doesn't work in children. Poor sensitivity and specificity for LVH in children. So what are you allowed for absolute voltages? This is one of the normative value tables from Park and Gunneroth. 8 to 12 years of age, V5, 40 small squares, 39 small squares is the upper limit of normal. That is massive. That is easily crossing the line of the line above. Okay, so if you're getting this and you're not sure, do a half voltage ECG, and you can find that in the settings. It's usually not that hard to find. If you're still nervous about it, definitely send us the ECG. Okay. When someone sends me this, and I do think it is truly honest to God big, what am I thinking about? I'm thinking about why you've done the ECG. I'm going to ask you what the blood pressure is. I'm going to ask you what for family history of HOCM and things like that. I'm going to ask you about the QRS axis, the T wave axis, and deep Q waves, and whether there are big Q waves in the kid as well. We've already said about comparing to normative values. So this is the sort of thing you can get with just big voltages crossing the line above. This is nowhere near 40 squares, huh? And so you can get very big voltages in kids. Okay, so scenarios. I think the first thing to say is ECGs for murmurs. I think, honest to God, when people refer me a murmur, I'm mostly interested in the clinical status of the child. It's things like, what do the femorals feel like? Are they blue? Is it super loud, or is it just something soft you can hear? Is the kid well? Are they thriving? That matters to me more, I think, than ECG a lot of the time. And most of the time that's going to dictate how urgently we see the kid. And so the clinical information is really, really vital here. The high yield things and the more obvious changes in my mind are really the QRS axis and the R wave progression across the precordial leads. And that's why I look at these things, because I think they're high yield and relatively obvious. This is an example of a child that I added last night, and so I'm remembering, with a partial AVSD. So AVSD is very classical for giving you superior axis. And look at this. So 1 and AVF. So you've got so net negative in AVF. So the axis is superior, is pointing upwards. This is a kind of northeasterly axis. If you've got inverted AVF in anyone, actually, I'd quite like you to be showing me the ECG and talking to me about the patient. This is pretty much universally pathological. I will occasionally get an ECG with superior axis and find the heart is normal, but actually if you're showing me a net negative AVF, I'm going to be wanting to see that kid, and I'm going to be looking very carefully for a high VSD or a partial AVSD, or an AVSD, or a normal type AVSD, a complete AVSD. That's what I'm going to be thinking of. This is pretty much always associated with pathology. This is an 8-month-old. This is not going to have been a subtle thing. This is an 8-month-old, very dysmorphic child. Not much murmur, but very desaturated. It was already known to have Edwards, so it does make it a little bit easier. But this is pathological on several grounds. So the axis is a bit borderline, yeah, equiphasic V1. The R wave is still pretty dominant at 8 months of age. Very big. These voltages are very, very big. And this is going to be pathological for V2. These are not subtle things, and these are the high yield things. I'm sorry, I've given you 2 very obvious examples and not subtle examples, because I just want to show you what these things look like. Huh? Okay. So chest pain. I don't really mean acute chest pain here. I mean chronic chest pain. This is extremely common. And I'd say probably at least 1 in 10 of my patients in clinic will have some symptom of chest pain. But the number of patients I've ever seen with a true to God cardiac cause of chest pain is I think single digits. And actually the one that comes to mind, he was actually having angina, but he was a patient who'd had an arterial switch. It wasn't still, he had a great big scar down his chest, huh? But this is a symptom often allied with a huge amount of anxiety. And I think the families appreciate it if you just spend a bit of time and take a careful history. I really would, next time you got a patient that you think is coming to clinic with chest pain, I really would strongly recommend this paper written by non-cardiologists. So Mike Rixatis, Julian Legg, and I don't know who Collins is, but I think she was also here. As a really super review of causes of chest pain in children. And he's got really nice diagnoses. You can give names to these things. Things like precordial catch, which is when they take an inspiratory breath and they feel like they can't fully breathe in and they get a sharp pain. And that's a thing called precordial catch. And sometimes when you give these things a name, you say, we know what this is. It's very benign. It just makes the families a bit happy, and they go away and then they don't keep coming back to your clinic. Cardiac examination, rarely helpful. ECG is almost certainly going to be normal in these guys. Echo, unlikely to be helpful. When they come to our clinic, we end up doing this stuff. And I try not to, but I'm sorry, I really do end up doing it. The other thing to say is exertional symptoms. Again, exertional chest pain, very difficult to say it's nothing, but even then, exertional chest pain, rarely do I find an ischemic thing. Exertional collapse is a different thing. An exertional collapse, I always want to see these guys, and I actually spend a lot of time looking at these guys. And if I don't find stuff, I end up MRIing them and stuff like that to be sure the coronary course is normal. The thing people worry that they're going to miss is with exertional pain is the coronary running between the 2 great arteries or something like that. Usually that just causes collapse. That doesn't cause chest pain. It usually causes collapse. Okay. Okay. Palpitations. So when you take a history of palpitations, when I take history, I'm trying to make a story for SVT. And the high yield stuff is abrupt onset and offset and associated symptoms. The other slightly unusual question that I ask is I ask the parents if they could tell that the kid is having palpitations without the kid telling them. So a lot of the time it's the kids which run the surgery, oh, I'm really happy, I've got heart racing, and then just keep plowing on. As opposed to the parents go, oh, the kid looks a bit pale. Are you all right? You've gone very quiet. And there's a subtle difference. Would the parents have noticed if the kid hadn't have told them? All right. And I usually find that's got a reasonable yield. The decision then becomes which tests to do. And that's really dependent on the frequency and duration of symptom. So taking a history around that is really important. The ECG is just essential. You should just be doing ECGs for patients with palpitations. It might be diagnostic or just intermittently diagnostic. So delta wave in Wolff Parkinson White can be an intermittent thing. Okay, you can only get that, and sometimes you can only see that intermittently. So more than one ECG is often helpful. What am I looking for? I'm looking for sinus rhythm with normal conduction. What does that mean? That means an upright P wave in one an AVF and one P wave to every QRS and a normal PR interval of 3 to 5 small squares. Okay. A delta wave, PR interval, I'm actively screening for these things and make sure that the PR is normal. I'm going to check the QT. I'm going to check for Brugada. You can get palpitations in those. Usually they're more terrifying. I'm then thinking about some form of medium-term monitoring. I occasionally supply a letter for the parents to take, particularly if they've had this is a kid or something that have had prolonged palpitations and they've gone to A&E on more than one occasion and they've just been sat waiting in the waiting room and the palpitations have gone away. And that becomes very frustrating to families. And only once has this actually truly worked. And I occasionally just write a letter saying, we are investigating this child for palpitations. We think it is highly likely they have SVT. However, we have not proven this. We'd be grateful if this child comes to your department, if you could try and expedite a pulse check and an ECG. Okay, and once that has helped. Okay, so rhythm monitoring. So 24-hour tapes I request reasonably frequently, especially with frequent symptoms. And I don't mind too much with 24-hour tapes. The problem with longer periods, and particularly 7-day tapes, is some poor person has to examine that tape. 7 days of tape is a real painful thing for some poor person to look at. And actually, it takes quite a lot of person hours to get that examined. So I've got to have a real good reason. I don't ask for a lot of things longer than 24 or maximum 48 hours because it takes a lot of person hours to read that tape. That's a tape. There are other things, and some departments have these things and others don't. So this is a thing called the King of Hearts. This is super. I love King of Hearts. So although it looks like it was made in the 1940s or something. So what you do is you put the ECG stickers on, and you leave the machine connected. And you can have this for weeks at a time. And you only press the button when you've got symptoms. And it records a bit before you press the button and a bit after you press the button. So you may get onset and you may get offset of tachy as well. And it doesn't require someone to sit down for hours to tick through all your 7 days of heartbeats, okay? There's a thing called a cardio memo. So I'm kind of going off cardio memos a little bit, although we can supply these and we have them in Southampton. So what you do with this is, you see it's got some little silvery dots on. What you do is when you get symptoms, you hold it to your chest and you press the button and it records. The quality of recording is variable, but I have had some good hits with these. And again, you can give it out for weeks at a time, and you don't need someone to sit and report every heartbeat for 2 weeks. Smartphone-based things. So the one I've most experience with, although I promise you I don't own shares, is something called Cardia, and some pediatrics departments have bought these and give them out to families, and basically it is as a picture. You put your fingers on it and it records your heart rhythm, and these are super, and we've had a real good number of hits with these, and you can give them out for weeks at a time. Some families want to buy their own. My dad bought one because someone told him he once had AF, and I got tracings for about a year afterwards, and so you can buy them. They're about 120 quid, I think, and they can be super. We've had some good hits with those. Bottom of the line for children, but not necessarily for adults, is a reveal device, and these are absolutely super. And modern reveals are about the size of, if you get 4 slightly long matchsticks and put them together, that is the size of a modern link. They are magic. In kids, we surgically implant them under GA. In adults, it's done under local. You put it under the skin in the chest over the heart, and the battery lasts for about 3 years. And you tell it what you want to record. So if the link sees something that it thinks, oh, no, that's really bad, I'm going to record that, it will automatically record. You tell it what low rates to record and what high rates to record, and it just quietly does its work. If the patient has symptoms and then you want it to record, there is a hoofer that comes with it, a sort of remote control thing that you hold over the device and you press the button and it tells the machine to record. It tells it to record. Downloading is done wirelessly. We give them this little box that goes with them that sits next to the kid at night in bed, and it automatically downloads itself. And if the reveal has seen anything terrifying overnight, it just sends it. It just sends it automatically. The CRM, the rhythm management people, every morning just open up their inbox and get terrifying downloads from links that have been recorded over the preceding 24 hours. It truly is magic. They're wonderful little devices. Okay, so management. I'm going to do a bit on, I know this isn't ECGs, but I want to do a little bit on management of tachyarrhythmias because I think this is really important, and I think previous groups have found this valuable. When you ring me about a patient with tachyarrhythmia, my first question is, so the first thing people want to tell me is that the heart rate is over 200, and I'm kind of whatever. I mean, I'm not that bothered about what a heart rate actually is. I want to know how stable the patient is with that. And it's sometimes quite hard for me to get that out of you because the heart rate of over 200 is just the overwhelming thing. I want to know what the patient's like. I wonder if they're warm around the edges, if you've got decent blood pressure, if they look well. I'm then going to want to know what the ECG looks like. And I'm probably going to want you to send me the ECG. The situations in which I kind of want you to call before you manage it, because most of you guys can all manage SVT. You can all manage a narrow complex regular tachycardia. You can do that. But if it's irregular or broad complex, I would quite like you to give me a ring. Now, most of the time, even if it's broad complex, as long as it's regular, I'm going to get you to give some adenosine anyway, because the most common cause for broad complex tachycardia in a child is actually SVT with aberrant conduction. And so you've got, and the pathophysiology of this is your bundle branches can only conduct at a certain speed. And some people's bundle branches don't deal well with 200 or even 180 plus. They don't deal well with that. And so you get bundle branch block and it comes up as a broad complex tachycardia. But if it's an SVT, it's going to be regular. And so I'm going to give adenosine anyway, because it may all cardioverter. What I worry about is this. So this is clearly a broad complex tachycardia, and it is not regular. If you just spend a second staring at the screen, looking at the RR interval between the beats, this is actually irregularly irregular. I've got another slide of this coming up. This is pre-excited AF, and this is bad. Okay, this is bad, and you want to call us soon, and do not give the child adenosine. Or really bad things will happen. Okay, so adenosine. Adenosine is magic. I want to talk a little bit about adenosine. So the half-life is in seconds. When I administer this, I attach the cannula with a 3-way tap. I give the adenosine, and then I turn the tap, and then I flush it. There is always a pause. Okay, sorry, you should have an ECG running during administration. And I would like, at minimum, the limb leads. I would love more leads. An electrophysiologist like you to have all the leads, although that is often challenging to achieve because it's just a very crowded sheet of paper. Minimum limb leads, please. The next thing to say is you've got to wait a proper length of time before you've decided that it's done nothing and you need to give more. There is a good reason for that. So for the adenosine to take effect, it's got to get to the SA nodal artery. It's got to get to the coronaries. So it's got to go through the venous circuit, up the IVC or SVC, into the right atrium, right ventricle, PA. It's got to transit through the lungs, LA, LV, up the aorta and into the coronaries. It's got to get all the way around the circulation before it will do anything, okay? Your other options, DC cardioversion, amiodarone. There are others, but we're getting further down the line. I want to talk about this situation. So often people have tried to cardiovert with adenosine and they get reinitiation of tachycardia, okay, in a relatively well-looking child. But they phone us and say, I've given adenosine and it's done nothing. It's not done nothing. I guarantee you it's not done nothing. It's caused you huge anxiety is what it's done, because you've had bradycardia and block and everything's gone very slow. As long as you've got, if you've given adenosine and you've had bradycardia and block and you've had sinus rhythm come back for no matter how brief, even if it's 4 or 5 beats, and then it's worked. The adenosine has done its job. The problem is that the tachy has reinitiated, okay? If you want to give more adenosine, you're just going to make the period of block and bradycardia longer. It's not going to make it more likely that the kid stays in sinus rhythm. It's just going to give you more anxiety. My recommendation in this situation is you give us a ring and we have a chat about the condition of the kid. And I'm usually going to say, give a little bit of, I'm going to give a little bit of usually propranolol is my personal preferred agent. And I'm going to get you to wait 30 minutes as long as the kid is fine. And I'm going to get you to give more adenosine. And almost certainly, I pretty much guarantee you, you will then cardiovert and stay in sinus rhythm. Pre-excited AF, I kind of mentioned this already. This is bad, and you're going to want to be giving us a call, and we're going to be wanting to manage the patient very carefully. Adenosine is absolutely contraindicated. Then I'm going to skip quickly over. So we're going to have a long-term plan about medicines and ablation. Okay, so collapsing kids. This is very common. The non-cardiac stuff, I'm going to want to be trying to keep as far away from as possible. And when I see these patients in clinic, I'm trying to make a good story. I'm trying to elicit a history of vasovagal syncope. And it's usually about having precipitants being standing up, hot, standing up after sat down a long time, hot baths, postural symptoms, getting out the shower, vasodilatation symptoms, stood up for a long time, and feeling lightheaded, dropping, and then waking up relatively quick afterwards, okay? POTS I want to keep very far away from. I regard this as an autonomic problem, and none of us really want to be trying to see these patients in clinic, although they do come, and I think in all honesty, I think I struggle as much as everyone else does with management of these patients. How do you know it's cardiac? Well, these are the cardiac things that generally that I worry about, that I'm thinking about as causes of collapse. What makes me think of these things? History not fitting vasovagal. And actually one that came up very recently, I don't know if there's a great pickup by Mike Rowe recently of a patient that sounded a bit vasovagal, but was only about 7, 8 years old. And he thought a bit young to be having vasovagal, did a tape and found daytime Wenke back, which is unusual. And we've done another tape and we've got 2 and 3 to 1 block. And we're currently working this kid up now. So things not quite fitting. Doesn't sound right for vasovagal, yeah? Exertional symptoms. If you're collapsing during exercise, I absolutely want to see you, right? Unusual circumstances. So things like you only have, keeps on collapsing, but has these collapses, but only when they're febrile. That would make me think of Brugada. Events in relation to water makes me think of long QT1, very classically. diving into water. Events with loud noises, telephones and alarm clocks are known triggers for torsade in LQT2 or strong emotion. Events during sleep, LQT3, right? These are unusual times to be, having events. Patients with cardiac, I've not put cardiac arrest on there, mostly because I'm pretty sure you're going to be referring patients to us if they've had an out of hospital arrest. I'd hope you know that already. Family history. So things in the family history. So I ask about, and I apologize at the start. So I'm really sorry. This is a scary question. Has anyone died unexpectedly or for unexplained reasons at a young age in the family, either side? This is a slide from Shankar, and Shankar suggests fatal single vehicle accidents as well. I ask about collapses, whether people have got pacemakers or ICDs in, all right? A medication history can often be useful as well for QT prolonging drugs or things contraindicated in Brugada. Okay. I haven't got much time left, so I'm going to try and beat through very quickly. So hypertrophic cardiomyopathy. If you have collapsed due to HCM, you are not going to have both a normal examination and a normal ECG. In fact, if you're collapsing, I would say your ECG will be pathological and not subtly so, all right? If you've collapsed due to outflow obstruction due to HCM, you're going to have a very loud murmur. Not a quiet murmur. It's going to be a proper LVOT outflow tract obstruction, harsh murmur, all right? If you've got HCM bad enough to collapse, you're going to have some of these changes. So you're going to have Q waves, T wave axis is going to be abnormal. You're going to have ST segment changes with reciprocal, You're going to have axis that is abnormal. This is an example. This is I think a 3-year-old with hypertrophic cardiomyopathy. Check this, inverted T in 1, inverted T in AVF. There's ST segment depression. There's reciprocal change in AVR. These lateral leads, T wave inversion. This is not subtle, LQT. Each time I do a talk on LQT, I recheck Wikipedia to see how many new types of SVT there are, and this number has grown steadily over the years. Some of which, in all honesty, I regard as just research stuff. We talked about measuring QT intervals. The other thing that is abnormal, that is useful, actually very much for electrophysiologists, is the T wave morphology, and they're very characteristic patterns with each type of LQT. They are good at that. I am less good at that. There are specific precipitants which we've mentioned. Exercise tests can unmask long QT changes, particularly during recovery. Genetics, vital in these guys, and hugely informative, maybe hugely informative. I think diagnosis of LQT can be really important as well, because you can suddenly unearth whole families of stuff, and you can save more than one life. I'm not going to talk about LQT stratification. There are whole ways of doing that. Brugada, so this is an inherited condition in which you get ST elevation. The ECG on the side is a very classic Brugada pattern. The cause of VF, this is usually with a type 1 Brugada pattern, which is the only truly pathological type. You can get, as we said, a subtle RSR, but not usually, and people are beginning to question how useful that is. But usually it looks like this, and you're going to send this to me, and you're not going to miss this. The diagnosis is based on ECG criteria, and occasionally, if there's family history and we're worried about it, we do an Ashmolean challenge. We find a genetic cause in about 30%. Catecholinergic polymorphic VT is as awful as it sounds. So this is a cause of predominantly exertional collapse. It is an inherited condition, and the classical finding is bidirectional VT on the ECG. So this up, down, with swinging axis, sort of axis inverting from beat to beat on exercise test. It's usually very classical. They need an ICD. Block. So this is usually going to be reasonably obvious on an ECG. So this is a nice example here. P wave, no QRS. P wave, QRS. P wave, no. P wave, QRS. P, no. And then you get to higher degree here. P, QRS. P, 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 QRS, P, P, P. So 2 to 1, 3 to 1. What I'm really looking for is complete heart block. Complete heart block itself per se is, if asymptomatic, is not actually an indication for pacing. If you've got complete heart block, particularly fetal complete heart block, and you are not, there are certain criteria for putting in a pacemaker. If you're collapsing with block, you definitely need a pacemaker. All right, guys, so quickly, so these three sources back again. I do believe quite strongly it's 2020. You don't have to store all these things in your head anymore. We can look them up. And I think particularly Park and Gunroth, this is a super book. If you want your own copy, it's got like worksheets and stuff you can work through, and it's a great learning resource, okay? All right, so some revision. What we've done is we've done revision. We've done some things that I'm sure there's a lot in this that people already knew, but hopefully there's been something new for everyone in here. I've tried to give you some idea of what I'm thinking about when I see these patients and what I'm working through, where to look for help. And actually, at the end of the day, you can always call. Okay, most of my colleagues, not most, maybe some, one has openly said to me today, Andy, I'm glad you're doing that talk and not me. Not all of us truly love ECGs like those strange electrophysiology people, but actually I do regard it as part of our job. If you've got an issue and you're not happy with it, don't tell them I said this, but you should just give us a ring, send it up, and in all honesty, if I'm not sure, I'll show it to Shankar Sadagopan. Okay, guys, thank you. That is a question mark I once found in the heart. I don't think I've got much time left, but I think I'll try and rattle through a few questions. Okay, go on. What do you got for me, James?
So, Sarah Bright has asked, what is that for nurses?
Oh. Do you know what? Is the ECG, who feels the ECG, do people feel the ECG made easy is unfair for nurses? Anyone in the room? I've got a nurse in the room. I don't think it's an unfair book. And actually, I think ECG Made Easy is a medical student level book. And I regard most nurses as just better. You can do it.
Good answer.
You can do it. It's not a hard book. How to Read Pediatric ECGs is more advanced. And actually, I'll be open here. Part of, I think it's chapter 2 becomes a bit wacky. But chapter 3 is normal ECG. Chapter 4 is normative values. Okay, there you go. I've even told you where to look in the book. What else you got?
Andy, can I ask one?
So King of Hearts is actually only available in certain trusts. Only certain trusts have this. I think if you don't already have it, okay, so Reading has invested, the Reading General Pediatrics Department, I know, has just invested in some cardias. They just bought 3 or 4 of them. In Leeds, the congenital cardiac specialist nurses have 4 or 5 cardias, and they give them out, and they give them with a stamped address down a packet for them to send them back when they're finished with the traces, and it works really well. If you haven't already got King of Hearts, I wouldn't bother, okay? Someone says, I love ECG Made Easy. Charlie Pugh says she loves ECG Made Easy. See, it's perfectly accessible book. What do we got?
Andy, can I ask, can you hear me?
Yes.
I'm ST5 Dr. Asad Naseem. One question and one comment. One question is basically, what is your experience in SVT patients with cardioversion? Like, thankfully, like I think I've only done one that went well. Most of the time it responds to adenosine. Comment is like, previously my understanding was like, if there is a syncopal episode, collapse with exercise, that's a red flag. But now you have shown us that it can happen, like the long QT is associated with the at resting as well. So it's a bit more scary. So yeah, so this was a comment. The first question I would like you to answer, please.
Sorry, so the question is, what is my experience of DC cardioversion in SVT?
Yeah.
So I would say, so if they're unconscious, it's obvious. This is a complete no-brainer. I think if they're awake, conscious, and have a good cardiac output, I would give them something to stabilize the circulation and give them some to stabilize the myocardium with usually propranolol or amiodarone if you prefer, and try again. Okay.
Okay.
If they have signs of compromise, then I think it becomes a discussion with your retrieval team. And I
Okay.
would get your anaesthetist and retrieval team out there and get us involved as well. And, you know, we can easily, what's it called? Conference call nowadays. And we can talk about it. And then if you've got signs of compromise in an awake patient and any tachycardia or any arrhythmia, actually, any arrhythmia. And in fact, I saw Kim Sykes online. I don't know if she's got a comment. But my feeling on this is, if you've got a patient who's compromised, you want to be calling your retrieval team. You want to be, and you can't cardiovascular. You want to call your retrieval team. You want to be calling us, and we want to be having a chat about it.
Okay.
Because the decision to put these kids to sleep is not necessarily a straightforward one, and it depends a lot. I've had patients go very badly who've properly had VT, who've had proper VT, not SVT with aberrancy. Yeah, we've proven it's VT, and they've arrested on induction, and it can be quite scary. So the decision's kind of shocking an awake patient is pretty rude. And you shouldn't do that, and it's not very nice. And so they should really be asleep. And so if they're not already asleep, you need to be careful. Events while asleep. The events while asleep thing, really, I don't mean they're collapsing in the sleep because they're already asleep. I mean arrests, really, and seizures and stuff like that you can get with it. And usually that can be patients with sleep seizures and stuff like that, and they have an ECG and people find a problem. Does that make sense? I think that I kind of borrowed that slide from Shankar and then I modified it, but I didn't quite modify it enough.
No, thank you so much. It was clear.
No, absolutely fine.
Clear.
I think I've been told finito. I hope everyone got something out of that. Yes, please be. Kim's just said, please be very careful giving boluses of amiodarone if poor cardiac output. Exactly correct. In fact, we had a problem with this the other day. But the drug, I think, if you've got poor cardiac output and the patient is compromised, we need to be having a chat. We need to be having a chat with the retrieval team and as a team making a safe decision. I think that's a really important thing. That's a really important thing. Okay, guys? It's 2020. We can talk to people. We can get support. Okay? Thank you all.